Hi there and welcome. My name is Dr. Marlena Jabara, and I'm an American board certified radiologist specializing in podiatric radiology. Let's take a look at an overview of pedal bone tumor assessment. I or a related party have no financial relationships to disclose. Our objectives will be to review specific principles of imaging evaluation of the most common bone tumors of the foot and ankle. I'll take you through imaging modalities, tumor morphology, age, matrix, and location. We'll review patterns of X-ray bone tumors of the foot and ankle, and also review bone reporting algorithms to help identify who needs follow-up using bone RADs. The evaluation of the bone neoplasm can begin with understanding a schematic such as this. There are different parts of the bone, not only in the length of the bone, the diaphyseal portion, or the widening waist-like metaphyseal portion, or the physis or epiphysis, but also the layers of the bone. Is it adjacent to the cortex, juxtacortical, intracortical? Is it eccentric, like a fibrous cortical defect, or is it more centrally located, such as something like a fibrosarcoma or even fibrous dysplasia? Furthermore, we're going to look at the age and sex of the patient to give an idea of what tumors are occurring at what age. Are there single or multiple lesions? That can be very important in denoting, is this metastasis or is this a primary lesion? Again, the location in the skeleton, what bone is involved? Is it a toe? Is it the ankle? These are different locations and different tumors occur in different areas. And also the location within the particular bone, just as I mentioned, is it extracortical or intraosseous, eccentric? And the morphology, are the borders clearly defined, or is there bone destruction, periosteal reaction, matrix, or an associated soft tissue mass? All of these features we'll take into account when we assess whether or not there's a bone tumor that needs further workup. X-rays, what's the value? Very important for assessing growth rate. We can see the zone of transition, which is when we can determine where the normal and abnormal bone is and what is the border between them. And whether or not something has a periosteal reaction. Is there an aggressive feature to the lesion that's causing some active change to the cortical bone? And whether or not the matrix is osseous, cartilaginous, or fibrous. In this case, we can see the stipple ring and arc type of chondroid matrix, as opposed to this. This is an intraosseous lipoma with a central calcification. So cartilage, we'll take a look at all of these features of different matrices. MRI, we can visualize the entire bone and the adjacent joint. This is very important when we're talking about osteosarcoma, which may be related to skip lesions. So we'll need to see the end of the joint. It has superior soft tissue contrast, the ability to see within the bone and even the little trabecula within the bony structure with detail. We can see within tendons and even the wall of a blood vessel. We can see the difference between the flowing blood and the actual wall. That's the ability to see within a soft tissue structure. We can identify skip metastasis, again, visualizing joint to joint, and assess for preoperative planning, whether or not the tumor is very close to a neurovascular bundle and whether we'll have to exercise some precautions for that. In addition, the signal intensity of the tissue is so valuable, this information that we gain on MRI, and the different tissues that we can see, hematoma, fat, muscles, nerves, hyaline cartilage, all of these guys. Hyaline cartilage, whether or not something has fluid, tumors, lipoma, hemangiomas, all have different T1 and T2 weighting. And when we talk about these weighting characteristics, it's the relaxation of the different protons within the substrate that tell us something about the cell types that are living within it. Something that has a high T2 weighting, something that might be fluid or have hematoma, or something that's of high T1 weighting, something that's seen in fat. When we're looking even at the morphology, we can see that on this fluid sensitive sequence, we have quite a bit of elevated T2 signal, but also that there's a layering portion of this. So fluid levels, another clue that we might be dealing with a lesion such as an aneurysmal bone cyst or a sequestrum or some type of blood layering products. In addition, is the lesion high on T1, but what is the morphology of that T1 elevation? Is it a hematoma? Is it normal fat? We can see normal fat here. We can see that this lesion is different from our normal fatty marrow. So we get to infer different information and different data is gleaned from the T1 and T2 weighting. CAT scans. Superior spatial resolution, subtle cortical erosions. We can see subtle calcifications and determine the matrix. So seeing within a lesion can help us decide, is the lesion made of an osteoid tumor, or is it a chondroid tumor? Or in this case, is the lesion creating a fibrous matrix? This is a ground glass lesion with endosteal change in a patient who has a fibrous dysplasia in this lesion. In the evaluation of the bone neoplasm, as we move through our chart, we can see that the age of the patient can predict the type of tumors that will occur during those ages. Well-defined lesions occurring early in life, EGRAN and simple bone cysts. Less well-defined Ewing's, osteosarcoma, leukemias, and of course, sclerotic osteosarcoma in this young age group. The older ager groups, 40 and up, metastasis myeloma geodes, in the well-defined category, ill-defined Mets, myeloma, chondrosarcoma, high-grade, and of course, sclerotic lesions such as metastasis and bone islands. In the 10 to 20-year-old age category, that's where we get our bubbly lytic lesions, the non-ossifying fibromas, the entire list, all the way down to chondromyxoid fibromas. Less well-defined, those are more concerning Ewing's, eosinophilic granuloma, and osteosarcoma. And of course, our sclerotic osteosarcoma is still occurring in this age category. For 20 to 40 giant cell tumors, enchondromas, chondrosarcomas, we can even see brown tumors in this population. And of course, ill-defined, we'll be concerned about giant cell tumors, and sclerotic lesions in this category often come up very commonly, enchondromas, osteomas, bone islands, parosteal osteosarcomas, and other healed lesions that we saw in our young adult grouping. Looking at the morphology, this will help us determine patterns of bone destruction. A geographic lesion is well defined and will affect a sharply indicating margin. And we can see that here in the distal radius in a patient. This is a giant cell tumor. A moth-eaten pattern is where we have lesions that are about 3 to 5 millimeters in lucency and creating this effect of this lucent region of the cortex. It's a moth-eaten superimposed. This is an aggressive, rapidly infiltrating lesion. And of course, these permeative types can be very difficult to see, but notice that there's a change in the cortical layer as we move towards the metaphyseal region. There's a lesion that is permeative, very characteristic of round cell tumors, in this case, a Ewing sarcoma. Further evaluating geographic bone destruction, we can see that they're given different gradings, 1A, 1B, and 1C, based on the degree of completion of the sclerotic margin, 1A being complete, down to 1C being there is no perceptible margin, and 1B in between where we may see portions of the margin. And of course, the sclerotic margin indicates it might be slow growing. The less margin you see may indicate that there's a wider zone of transition and it's more aggressive. So that's the meaning of the geographic border and its loss. Moving on to other examples of this, moving to, say, a 1B lesion, we're looking at an aneurysmal bone cyst where we cannot perceive the border at the superior aspect. We can see some of the border here. Notice this is a grade 1A, a very well-defined border, intracortical lesion, a non-ossifying fibroma. Moving on to moth-eaten, these are less well-defined patterns, longer zones of transition, and the differential diagnosis often includes malignancy versus infection. Infection can look aggressive, so we always want to include that so we don't miss that diagnosis. And we can see here is our example in the femur. We're seeing these lucencies in this area. Also, an aggressive lesion, lucent, incomplete border is identified here. Taking a look at this proximal humerus, we can appreciate the changing subtle zone of transition where we have these more smaller coalescing areas of lucency along the proximal humerus in this aggressive lesion. Another example of an aggressive lesion where it can be hard to say where the normal and abnormal bone begin and end. And this is an example of the permeative pattern of aggression. Moving on to matrix, we can identify chondroid matrix by its popcorn or ring and arc type. Sometimes it's described as stippled, versus the osseous cloud-like snowstorm patterns in this patient who has osteosarcoma. In our patient here, cartilage, further examining cartilage tumors, we can see that stippled ring and arc type of pattern of calcification that is seen in a benign enchondroma. But other types of cartilage tumors include chondrosarcoma, chondroblastoma, and chondromyxoid fibroma. Bone tumors, we can also identify the location. That can be a very helpful, important part of our data set, understanding whether something is intracortical, because we can see on our charts that intracortical lesions can include non-ossifying fibromas and chondromyxoid fibromas even. And we can see in this lesion in the distal fibula, we can see that it is slightly expansile and has some type of rim enhancement on this post-contrast T1 fat suppressed image of a coronal ankle. We see the expansility. We see that it is forming part of the cortical layer, and this patient who has a non-ossifying fibroma. Let's talk about periosteoreaction. This is a very important assessment that we can make to determine whether something has aggression. The aggressive bone pathology can cause an erosion or penetration of the cortex and invoke a periostitis. Different types of periostitis can tell us that this lesion is indeed aggressive. Something like this would be the onion peel or Codman's triangle. We have the sunburst pattern and hair on end type of periosteum, very aggressive appearing periosteoreaction in this patient who has a osteosarcoma. Notice in this case, we have a lesion here. It is a lucent lytic lesion. It is penetrating the cortex and creating a very aggressive lamellated periosteoreaction with an additional lobule of periostitis. The periostitis is laying down so quickly that it cannot actually incorporate into a solid layer. And so when we see this cortical onion skin or onion peeling, we know that this is occurring very rapidly in a patient that may have either infection or cancer. The bottom lines for tumor assessment, we want to know the history. Did you have a malignancy in the past? The morphology of the lesion. What are the borders of it? What is the age of the patient? Is there matrix that we can define? Is it chondroid or osteoid or fibrous? Where in the bone is it? Is it in the cortex? Is it in the intramedullary space? Does it have a periosteoreaction? And what are its signal intensities? These are all important features. As we can see here, we have this lesion. It is geographic, and we can see this lucent lesion in the metaphyseal region. Notice also that there's some kind of poor definition around it. This patient turned out to have a Brody's abscess. This is actually an infection with a type of patchy, ill-defined border around it. So very common Brody's subacute osteomyelitis and Brody's abscess. Let's take a deeper dive in looking at some more examples of evaluation of bone neoplasms just to keep practicing. It takes a lot of practice to be able to see the correct orientation and be able to understand what's geographic, what's permeative and moth-eaten. When we're looking at patterns of bone destruction, this is a great example of a geographic, very thick-walled lesion that's occurring within the cortex. This is a grade 1A. This is consistent with a non-ossifying fibroma. It can be lobulated and geographic, and it can even be multicentric, where we can see in this case it's a grade 1B. We see part of the lesion is sclerotic and part of it we do not have borders to. Moving on to this grade 1B lesion, we can see it's still geographic. We can still tell that there's a lesion here and there's not a lesion here. But what we can see is where are the complete borders of the lesion. So that's a grade 1B. Moving on, we can see now a moth-eaten type. These lucencies are quite destructive and aggressive appearing. Another example of moth-eaten, where we're seeing these multiple areas of lucency over a region where we don't coalesce the lesion. We can't actually define the geographic portion of the lesion, just multiple lucent lesions in a moth-eaten pattern. Notice here, even becomes more aggressive, very irregular. We can see changes to the cortex. This is an aggressive lesion. Lastly, a permeative pattern. We can see there's areas of lucency that are over a length of bone, not any one particular area, but very aggressive appearing lesion that's involving not only the intramedullary region, but the cortical layer in a grade 3 permeative pattern. When we're looking to evaluate the penetration of the cortex, it can be very important to understand that in a geographic 1A lesion, we have a complete rind around of sclerosis in a absolutely benign non-ossifying fibroma. We notice as it becomes slightly more expansile in this particular lesion, there's endosteal involvement, and we'll be looking to characterize whether or not there's any cortical breach, or is this 50% or greater involvement that may indicate that there's more aggressive features to the lesion. And of course, you can clearly see there's a lucent lesion, there is a break in the cortex, and perhaps even the suggestion of a soft tissue mass in this penetrating aggressive lesion. Moving on to a sclerotic rim and deciding whether something has a sclerotic rim versus something that does not. We can see again our favorite example of our non-ossifying eccentric lesion with a geographic complete rim versus something that we can see part of the rim, part of the capsule of the lesion, but the superior part very well poorly defined. So in this grade 1B lesion, we see some of the features where we know that the lesion is not extending past this portion, but superiorly, it looks like we cannot actually put a pencil around the entire lesion itself. So a grade 1B failing to have a complete sclerotic rim. And again, our expanded shell, whether or not that's absent in a very benign appearing lesion, it's still benign even with a slight expansion when there's no cortical breach. And of course, a grade 1B lesion having greater than 1 centimeter of expansivity can be something that we'll follow as something that has a more aggressive feature. Now let's turn to bone reporting and our data system called BoneRads. This has been recently published and really helps the clinician to determine how we're going to assess whether a lesion needs future imaging, whether it's benign, or does it need to go on to a biopsy. And the categories go 1 through 4 depending on whether or not we're going to leave it alone, it's likely benign, or it may be benign but it's incompletely assessed and we'll need additional imaging to figure that out, or we can't tell. We see a lesion, but it needs follow-up in time, and it gives coordinates. And lastly, if it's a suspicious for malignancy and sent straight to the oncologic referral and or a biopsy, perhaps they will determine what type of imaging they'll need preoperatively. And these plates are available for your review. I will go over some of the features, and you can further expand on that by reviewing this article in Skeletal Radiology in 2022. But when we're looking for incidentally discovered solitary lesions, that's something that solitary sclerotic or mixed density bone lesion on CAT scan, we want to ask ourselves some questions. Are there aggressive features? Pain is considered an aggressive feature. So if there's pain, it needs to be imaged. Yes, it goes to BoneRads 4. So if we see a sclerotic lesion that's painful, this may indicate that there's a high level of malignancy. Pain is an important feature, so we want to be sure to put a marker when we're imaging over any particular lesion and understand that. Cortical involvement. Is the cortex involved? Soft tissue extension, pathologic fractures? Is there an aggressive periosteal reaction? Any yes to this, we need to work that up as a BoneRads 4. But if the answer is no, we're going to ask, is there a history of malignancy? If there's a history of malignancy, that might be the type of malignancy that has sclerotic bone metastasis, right? Prostate does that. Breast does that. If that's not the case, and then we measure the density and we are seeing visible fat, that's great. We can say that that's an intraosseous lipoma. It's a fat-containing lesion, or it's a benign lesion that has associations with having fat. We move on. We can ask questions. Is there ground glass matrix? If there is, probably is fibrous dysplasia. Is there cartilage matrix? If there is, are there any concerning features? This is a very common category because we have a lot of enchondromas that are incidentally found. If there are concerning features, we're going to go on for an atypical cartilage lesion and work that up. If not, this is a very powerful thing that they found through evidence-based medicine, that if the lesion is greater than 5 centimeters, we're going to follow that onto a BoneRads 3 with interval follow-up. If the lesion is less than 5 centimeters, that's a BoneRads 1. We don't have to follow that. We can term that out as benign, and so on. So if the lesion is not entirely consistent with a benign lesion, we'll go on to follow it. And if it is consistent, we'll go on to stop there. This will help with utilization costs. Is there a high T1 solitary bone lesion? And this is another important category, and it's divided into 3 questions. Is the T1 signal higher than skeletal muscle? It has a lot of specific features that we won't go into at this time, but just we're looking at the T1 feature on MRI to see, is it higher than skeletal muscle? Is it higher than muscle or adjacent disc? Or is it something that's T1 signal seen in a fluid level? And those are important features that help us to then ask additional questions. And the results of these questions, if the similar signal intensity to fat on all pulse sequences, well, then it's a fat-containing lesion, BoneRads 1. But if not, we'll need to work that up with post-contrast. And if there are no post-contrast images, we would consider that as part of the workup. So we'll recommend that patient come back and get a post-contrast. And you can see if the T1 signal intensity is higher than skeletal muscle or the adjacent disc, and there is a dropout in signal, that helps us as well. If there's a drop in signal on out of phase imaging, that helps us to determine whether or not there's a bone RADS consider category 1 red marrow. If it's not available, that we haven't done that type of sequencing, then we can either bring them back and do in and out of phase chemical shift imaging, or we're going to get x-rays and a bone scan to help work that out. And lastly, in T1 situations where it's seen as a fluid level, we're going to proceed to the next plate, which helps us to determine whether or not there's really a T2 lesion that we need to follow there. And again, these are very complicated algorithms that you can review, but the positive part is that it gives us a framework to ask questions and logically work up lesions using our imaging to come to a basis where we can say it's either benign, needs a further workup, or go on, you need a biopsy for that. Looking at that low T1 solitary bone lesion or a high T2 lesion, these lesions we're going to divide based on whether it has high T2 or low T2. If a low T1 and a high T2 lesion, that's the part that yes to any of that, could be malignancy. If it's low T1, high T2, but there's no history of malignancy or there's no pain, there's no cortical involvement, no pathologic fracture, or no to any of these, we're going to ask ourselves, is this consistent with an enchondroma or a subchondral cyst? Benign features of an osteochondroma present? Is it an NOF, fibrous dysplasia? Yes to any of that, you go right to benign. No, that's going to be either you're coming back for more imaging and getting a post-contrast exam, or we're going to go and follow you in time and see the biologic behavior. If it's low T2, low T1, and low T2, we want to know, do you have a type of malignancy that would be sclerotic, prostate, breast? Is it in the sternum? These are important questions to ask, and they will help determine whether or not we're going to go on to do a post-contrast and then work that up with a follow-up. If any of the features of low T2 and low T1 are on there, and we have these unfortunate, if you do have breast cancer or you do have prostate-specific antigen elevation, high likelihood that that might be a sclerotic metastasis. And lastly, a low T1 bone lesion that is considered totally benign when we consider that if you have a low T1 and you have a high T2 lesion, but again, there's no pain, no cortical involvement, no soft tissue extension, then if the lesion is no to all those questions, that may give us a great amount of power to say you're a bone RADS 1 and you don't need further follow-up. And if we cannot be sure, then it will move you to a bone RADS 2 or 3, depending on whether or not you need to have a post-contrast exam to understand how aggressive this lesion is, or will follow you in 6 months. In summary, I provided an imaging approach to bone tumors of the foot and ankle. We looked at morphology, age, matrix, and location. We reviewed specific patterns in the evaluation of bone tumors of the foot and ankle. And lastly, I took you through the algorithms, how we review bone reporting, and how we direct whether we have further follow-up, biopsy, or confirm that it is benign using the bone RADS categories. Thank you for your time and attention. Next up, we're going to have common benign bone tumors spanning from non-ossifying fibroma and giving examples of all of these lesions all the way down to giant cell tumors. So stay tuned. Don't forget our wonderful charts that help us to differentiate based on the location, whether it's in the juxtacortical or intramedullary portion of different types of common bone tumors. And of course, references available for your review.